All right, here we are for our live panel, the live Q&A session for uh, telephone CPR and bystander response systems. We have several people that were in the panel discussion here live for your questions and answers, so I really appreciate everybody being over here for that. I'm going to skip the reintroductions at this point and just jump straight into the questions. And David Blevins, one of the things we talked a little bit about during the panel discussion was this whole issue about organizational culture when law enforcement is running the communication center. And something started coming up in the chat that I wanted to maybe expand upon a little bit. And it was about the prioritization of calls in the call center. And whether or not the patient that's having a cardiac arrest and needing those pre-arrival instructions for telephone CPR is getting the appropriate prioritization. Do you think in general the law enforcement agencies understand this issue, or is it more of an issue of competing priorities? Well, I've also got somebody breaking into a house and other issues that are on their radar screen that aren't necessarily on ours.
So you make a really great point there. And when we take a look at prioritization, a lot of times, whether intentionally or unintentionally, I think the answer is unintentionally, we a lot of times side with whatever our focus is. So if we have a fire-based dispatcher going to be there, we're going to have a fire-based focus. We have EMS, we have law enforcement. It's, there's always going to be some sort of bias towards wherever they are. The answer is just whether we have enough individuals there to do the roles that we need. The one issue is when it comes to a break-in or some sort of burglary, there is information they can gain. They could dispatch the units or some follow-up, but that's pretty much done. When it comes to telecommunicator-based CPR, that's something that's engaged because you're continually having that discussion. And so the idea is there other calls that are going unanswered? And because we have to make sure that not only that cardiac arrest situation is remains safe, but other calls have to go on as well. So I think when you couple that the time domains with whatever our primary focus is, it could tend to skew there. But they try to make sure and prioritize as they need to. But as more and more demands get placed on them, if there's not somebody to take some of that relief, you can end up with some decreased quality.
Yeah, and I suppose the staffing issue is all relative, right? You could even have a very large communication center, but if the volume is more than what they have capacity for, they're having to triage. What calls get placed on hold and which calls are getting active support. So I suppose it's not just an issue for small communication centers. It's for everybody, but the underlying assumption is that the staffing is what it needs to be, and that's not always the case. Obviously, in economically resource-constrained communities, they would like to staff more, but they might not have the funding to do so. And there's always those surges, right? I mean, there's the classic argument about how many fire stations or ambulances you need to have. You'd always like to have enough for, even the rarest of emergencies, but that's not always practical. So we've got that balance we constantly have to deal with. Tom, in your experience, how has that issue been grappled with prioritization of calls and competing priorities? Is your comm center law enforcement based, or do you do your own dispatch when you're at Hilton Head?
Yeah, no, it's kind of unique, and I'm so grateful that on Hilton Head we actually have our own PSAP that does just fire and EMS. And so on Hilton Head Island, if you dial 911, unless you hit like a cell tower off the island, which does happen occasionally, but most of the time you'll connect with 911 communications on Hilton Head Island. They'll ask, do you have a police, fire, medical emergency? If you say it's police, then they'll transfer you to the county. But for everything else, they will dispatch fire and EMS locally. So that's been a real blessing.
Again, let me remind everybody, if you have some questions, go ahead and put them in the Q&A box, but we're just going to continue the conversation here. As a number of issues were brought up in the chat and the panel that I'd like to expand a little bit about. John, from your perspective as an EMS educator, and educator overall, I mean, their education principles are certainly universal. This issue of organizational culture, is this something that can be dealt with through the education of the public safety telecommunicators themselves? And thank you, Julie, for the clarification on what the preferred term is. But anyway, my point is that, is this something that needs to be dealt with more at a leadership level in terms of organizational culture, or do you think it's a bit more of an education challenge with the public safety telecommunicators themselves in terms of prioritization?
I think it's a little bit of both. Thanks.
Okay.
And I say that because, the telecommunicators themselves, they want to do a good job. They're all great people. They have a really hard job that a lot of people don't realize how difficult that position is and how difficult it is to maintain, quality in that position. And they want the education and they want to be updated. That's generally not an issue. The issue comes in when comm center management, and not necessarily the shift supervisors, but the upper management and even the management above that, who has created this, whether it's a regional comm center and everybody has to be a participant, or whether it's a county sheriff or county law enforcement or emergency management, and everybody else is kind of in line, and calls are triaged, and they may be sent out to a PSAP with a push of a button. So once administration understands the importance of the public safety telecommunicator CPR concept, what it can provide, and how it can back up, and on the law enforcement side, how it can back up their officers. Many departments have AEDs in their vehicles, and the telecommunicator can support that. So it has to be come from the top down and from the bottom up. The telecommunicators themselves have to want to be part of the process. But I will tell you, my experience is the telecommunicators are always ready to give better quality information, to provide better quality information to the crews. And they're more than willing, at least the ones I know, more than willing to provide instructions for CPR and other medical emergencies, but CPR and AED use in particular. So to answer your question, yes, education helps. And there are a lot of great programs out there. I'll reiterate that they need to be, in short bursts, frequently, as we've talked about all for the last 3 days in education. But until administration buys in, it's going to be difficult for those telecommunicators who are facing the screens to get much done, because let's face it, they have to have the support. They need the financing, they need the education, and they need the personnel to be able to do it.
Yeah, and we're fortunate. One of the people attending with us today is Julie Buckingham with the Resuscitation Academy out in Seattle. And her background, as I understand it, is as a public safety telecommunicator. That's kind of her specialty, if you will. And Julie makes the comment about the disconnect with law enforcement. In more and more systems, law enforcement is part of the chain of survival. Absolutely true. And with your point on top of that, John, with their deployment of AEDs, in addition to starting chest compressions, and law enforcement's role in many places around the country, their oversight of 911 communications. Because the part of the rationale for that is most of the traffic for 911 calls is not fire, it's not EMS, it's law enforcement related traffic, which is why typically law enforcement, as Tom put it, rules the roost in those 911 communication centers. So, with any sort of multi-pronged public safety agency, all risk fire department approaches, there's trade-offs and balances that need to happen in the organizational culture to try to make sure the operational objectives get met. And David, you were making a comment to Julie. Let me let you make that more on camera.
So she is absolutely correct when we take a look at this. When we're talking about out of hospital cardiac arrest, as with some other emergencies, every individual that is involved, from the bystanders being trained to our telecommunicators being ready and relevant as far as answering as professionals they are, to our first responders, law enforcement, fire, emergency management, even other individuals that may be in the area, if utility companies and stuff like that, train, and if they're in the area they can hear, and then obviously a good quality EMS agency that's ready to respond. That is ultimate key. They've been talking about the chain of survival for many years, and the key is making each one of those as efficient as possible. You were making a comment just a little bit ago about 911 centers, and then as far as staffing in relation to their overall size, and obviously we all want more, but we live in an area that, even though a lot of people talk about this being a business, one of the things we have to do is look at the fact that no matter how efficient we are, we've got an inefficiency there. We have to have people that are ready at any moment's notice. And when you do that, it's got to be the whole system. So there's nobody that's left out. Our law enforcement partners are great, but the telecommunicators that are out there, they're challenged, and they're going to do as much to make sure that these individuals have a chance to survive. So I really liked her comment.
Yeah, and I think there's a lot more that communities could potentially do to leverage available resources. The idea that's always really intrigued me, David, is extending the idea of sending law enforcement officers out, but also other vetted public employees, whether they're meter readers, code enforcement, people that are appropriately vetted and would be okay to send to someone's home, with appropriate background checks and all of those sorts of things, to kind of help address this issue of cardiac arrests inside the home. That seems to be, one of our, if not the biggest challenge right now in improving our survival rates, is getting, hands on the chest and AEDs in place in those private residences. And so I just think there's more we could do with a bit more creativity in extending this idea of vetted responders to get more reach into there, with leveraging not just off-duty public safety personnel, off-duty healthcare workers. I love this program that they put together in the villages, from what John has described to us, where it sounds like, John, if I understand correctly, with that program, have they basically vetted the neighborhood responders, or is there community consensus behind allowing other lay persons to respond to homes in the villages? How exactly does that work?
Actually, I'm not 100% sure if they have a vetting process. I know that they started out with that thought process, that people would sign up and they would be checked out. A lot of their volunteers are retired healthcare providers, nurses, physicians, PAs, respiratory therapists, medics, EMTs, retired firefighters, retired cops. Because it's such a large retirement community, they have a large volume of those, and many of those are the people who are volunteering for this program. So I'm sure there's a vetting process. I'm just not intimately familiar to know for sure.
Yeah, and I've seen a different flavor of this approach. Where I grew up as a teenager in Central Florida, was right near a place called Sun City Center. And Sun City Center had their own little volunteer rescue
Still
squad.
does.
Yeah, and they have a lot of retired healthcare workers, et cetera, there. So it sounds like something perhaps similar to the village's model, but there the people were affiliated with the rescue squad rather than being more of the app-based, socially sourced response, if you will.
Yeah.
So,
And that whole concept works well there, because it is a contained community. They have this volunteer rescue squad that has been there for a very, very long time, and is valued in the community. And like you said, most everybody on it are retired healthcare or public safety providers.
Yeah, indeed. And we see the same sort of phenomena in a lot of these other retirement communities as well, in different scales. Different condominium associations with their HOAs will organize something. I happened to moved in for the first time into a gated community out in rural Tennessee, and we've been rounding up some AEDs and trying to get something put together here. So there's, I think, a lot of possibilities in trying to build our systems of care by, kind of supporting, encouraging, nurturing, if you will, some of these other types of community response programs that have occurred organically in some places, but take the lessons from the villages, the Sun City centers, the HOA complexes, find out what those best practices are and share them. Might be part of this, elusive elements of getting a more robust bystander response program. So we're at 30 minutes after the hour, so I'm going to go ahead and wrap this particular session up. Thanks everybody for being on the panel. Thanks for all of the message traffic in the chat, and appreciate all of your input on this. We're going to go ahead and end the session, take the break, enjoy the lounge, visit the suppliers in their booths, and we'll see you in about 30 minutes at the top of the hour. Thank you.
Take care, everyone.